Hello and welcome to MD Newsline. Thank you so much for joining us. Can you please introduce yourselves to our audience?
Go ahead.
My name's Dr. Olivia Wills. I am an accredited practicing dietitian and registered MS nutritionist and dietitian from Australia, as you can probably tell from my accent.
And my name's Karen Zozack. I'm also an accredited practicing dietitian, known here as an RDN, and I'm also a PhD candidate at the University of Wollongong.
All right, so dietitians aren't people that we normally think about when we talk about MS. Can you tell me a little bit about your roles in this field and also tell me about the work that you presented today at the conference?
Sure.
I
Yeah.
think I think in the early days of MS care, the focus tended to be medical, but what's becoming more apparent now as the research expands is that it's so important to involve all different members of the multidisciplinary team, and a dietitian is part of that team. So looking after the nutritional status and nutrition care of the person who's living with MS.
Mm. The I think the biggest flavor of this conference in particular is wellness, and that seems to be coming through in almost all of the sessions, whether it be clinical courses or symposiums. And wellness, yes, a subjective term, but in MS, it's becoming more and more established of including things like exercise, like speech pathology, and dietetics is a huge one that is coming through. I think if you were to interview us at a conference almost 10 years ago, nutrition would be an establishing area of work in multiple sclerosis. But these days, I think it's a lot more respected as a tool in our toolbox of how we can help improve the lives of people living with MS. So it's rewarding as dietitians to see that, and we're just here to keep fighting for our role and showcasing how dietetics can really improve the lives and management of people with MS.
Yeah, so talk to me about your awesome presentations here at the conference because I'm really interested to find out the impact of your roles on patient outcomes, just understanding the disease.
So, my presentation yesterday was focused on dietary factors relating to multiple sclerosis. So, thinking about risk factors for onset and also progression, but really putting that under the clinical dietitian lens. So, not necessarily looking at it from mechanistic
Mm.
research when you're thinking about nutrients and the impacts on processes they have, but taking a step back and thinking about applying the clinical lens to caring for people with MS. So, I started by I talked about three of the studies that I've been doing as part of my PhD. And the starting point for all of that was doing an online search for dietary advice for MS, because that's where a lot of people who have a new diagnosis start. The
Mm.
first thing they do is think, well, what can I do? The doctor's talking about medications, but is there anything I can do to help my situation and improve my outcomes? So that's a very common starting point. So I conducted a simulation of an online search for dietary advice for MS and identified 17 different eating patterns, and that's what I presented yesterday. Those eating patterns are quite diverse, so they're contradictory, and that can be really confusing for people who are trying to work out what the best diet is.
And increasing
Yeah,
the number of diets that are now being promoted or showcased online creates a lot of confusion.
absolutely, it does. Not only are they contradictory, but some of them can be restrictive as well. So
Mm.
that puts the person who wants to follow that diet at risk of deficiencies. And we don't want that for anybody who's living with multiple sclerosis.
Understandable. So, what are some of the trends that people are coming across when? So, I'm guessing these people are newly diagnosed and looking to see what they can do to help along the way of their treatment journey. And it sounds like there are some trends that come up online or wherever they find these diets. What are some of those trends?
Here in the States, there's the Wahls Protocol. So that's a modified Paleolithic eating pattern. And I can sort of talk about how I compared that with dietary guidelines in a little bit. But that is a restrictive eating pattern. It does have restrictions on certain foods that are recommended not to consume.
Mm.
So that's very popular here in the States. It originated here, and people are probably quite familiar with that one. It has three different levels of restriction as well. In Australia, there's the Overcoming MS diet, and that is a plant-based approach. It has some pescatarian elements as well, and it started there, but it's a bit more global now. So some folks here in the US are following that one as well. There's another one called the Best Bet diet, also. I think that one's from Canada. And what's the other major one that I wanted
We've
to
got swank
mention?
diet as well.
Swank diet was one of the earliest ones, so it's a low saturated fat approach, and that was one of the earliest eating patterns from the 1950s that was proposed for multiple sclerosis.
Interesting. So, what is the premise of the efficacy of these diets? Why? I mean, I'm sure they are slightly different, but what is the idea of what these diets are going to do for people that make people think that they're going to have a positive impact on their MS journey?
I think it really boils down to the effects of certain components of the foods that are included or excluded from those diets and the effects that they're going to have at the mechanistic level of disease activity. So, one of the big ones has been the effects of saturated fat. Thinking about also vitamin D, something that we do get from food as well as exposure from the sun, and thinking about how those nutrients regulate our immune system and therefore the disease processes and severity of disease in MS.
I think there has been a bit of a change in how diet and these dietary patterns are viewed in the MS community as well. I think when a lot of these are first promoted or established through groups in MS research, it's or the lens is to really cure MS. And from an MS community perspective or consumer perspective, they seek to change whatever they can to try and get some kind of control over disease. And we see that a lot with exercise, so anything that is modifiable. And from the dietary perspective, I think that's why there's a huge interest in that area. As we're getting more established with evidence and evidence-based practice and best practices for MS care, I think that lens is shifting from more diet will not cure MS to our knowledge at this point in time. And that's not something that we advocate for, but as a form of like I said before, it's a tool in our toolbox to better care for people while living with MS. And I think that's one of the key messages that we really try and showcase through our research is that while we don't have a cure at the moment, people can be living better with MS, and diet is one of those strategies.
And that's a completely understandable response as well for somebody who's newly diagnosed to want to do everything that they possibly can, including thinking about a potential cure as well through whatever means possible. So we completely understand that process, and that's why as dietitians we really try to think about how we can address some of those thought processes that are happening and sort of bring them back to maybe a more realistic approach to diet.
I think in follow up to what Karen was saying, there's a whole lot of MS specific diets, but the good thing, or I think the leverage that we can call on, is that we're both clinicians as well. So from the research, we actually consult and see people living with MS through dietary consultations. And outside of just these MS dietary patterns, people are following or trialing things like gluten-free eating patterns, dairy-free eating patterns. So ones that are quite common in the general population. But again, it always comes back to that sense of what could I do to better manage my MS and help my symptoms while not always being evidence-based. And I think that draws back on the role of dietetics in MS, establishing the evidence base and leading people to better eating patterns that may not put them at risk of other complications as a result of that.
Exactly right.
You were going to continue talking about your specific.
Yes. Yeah. So
Yeah.
the second part of my research has been focused on acknowledging that nonprofit organisations like the National MS Society here in the States recommend that people follow an unrestricted diet, but one that is a healthy approach in accordance with dietary guidelines. It's the same in Australia with MS Australia, and around the world, indeed, in other countries as well. So if that's the case, however, we've identified a lot of other eating patterns for MS. How do they compare with those dietary guidelines? Are they aligned with the official recommendation, or do they diverge? So the second part of my research looked at developing a tool. I called it the MS Diet Risk Tool. It's about to be published, very close now. And I started by defining those different eating patterns by summarizing them so that I could compare them with a summary of dietary guidelines. I started with the Australian dietary guidelines, but then expanded it to other countries. I had assistance from colleagues in the US as well, so that was absolutely wonderful to involve them. And we took the summaries of the eating pattern and the dietary guidelines and compared them and went through a scoring process. What I emphasized yesterday was that we're not in any way judging these diets. We're not saying that diet A is good and diet A is bad. we're simply comparing them with dietary guidelines. And the purpose of doing that is to identify where there may be nutritional risk attached to that eating pattern because of restrictions. So that was the second part of what I've been doing. And the aim is to eventually package that into something that can be used in the clinic. So you can see, okay, we've got our food groups. Let's color code that to identify where restrictions exist. And then we can use that to support conversations between clinicians and people who are living with MS. And I suppose it's a good time to say that we don't want to enforce what we think necessarily on people who are living with MS and wanting our advice in making dietary decisions. But our role as dietitians is to inform people with their consent, of course, so that when they're going into making decisions and they may choose to follow a restrictive diet, that they're doing it with their eyes open, so they know that there is risk attached.
And safely.
Exactly right. And then to follow them up to make sure that they don't become deficient, that we're checking their nutrient status, and that we're taking strategies into consideration if they do start to decline nutritionally.
What are some of the pitfalls of having nutrient deficiencies that impact a patient's journey?
So micronutrient deficiencies obviously are very significant. But we can also think about macronutrients and that is carbohydrates, proteins, fats, and fiber. So just to illustrate with an example, I talked yesterday about fiber. So let's say we're thinking about the grains food group. And let's say we're looking at an eating pattern that doesn't allow any grains at all, or maybe has a partial restriction like gluten-containing grains. So there's a risk that the person that's following that diet won't be getting enough fiber from their diet, as well as other vitamins like B vitamins, vitamin E as well. But thinking about fiber and how that's relevant specifically to someone who's living with MS, and Olivia can speak to this from her case studies as well, that person may have constipation because they may have neurogenic bowel. They may have issues with diarrhea as well, may find it difficult to control their bowels. So fiber is a really important nutrient that can help them manage that symptom. Again, that nutrient is not going to cure their MS, but it can help them with a better quality of life. So if they're not getting enough fiber because they're excluding grains, then really they need to look elsewhere in the unrestricted food groups, so fruits and vegetables, to help build up their fiber intake to make sure that they're getting enough of that nutrient. So if we're observing that, okay, they're restricting grains, how can we help that person? We can give them strategies to adjust their fiber intake to help them manage that symptom.
If I can even bring that down to a micronutrient level as well, in multiple sclerosis, and this is through experience from clinical work and patients that I see in private practice, B12 deficiency is really common. And some of the diets that might be excluding animal sources of protein or following like a vegan or vegetarian style of eating pattern, if they're not getting enough sources of vitamin B12, that can lead to things like neuropathy. In MS, we know that tingling sensations and nerve damage and numbness sensation, especially in like the lower limbs, is really, really common and a symptom of MS. So I've had patients attend practice and think, oh my gosh, my MS is worsening. My tingling sensation in my feet and in my ankles is really heightened at the moment. And we actually found that they purely just had a B12 deficiency. So supplementing that and monitoring that through a dietary approach, it saves the world of stress of then having to see a neurologist, getting a new brain scan, seeing if there's a new lesion or atrophy has increased. Managing that through a diet lens can be overlooked, and it's purely it could be something as simple as a B12 deficiency, for example.
It just highlights how important it is to, if you're a person living with MS and you're thinking about following an eating pattern that is restrictive, to reach out for support in doing that. To don't go on your own. Do it with supervision and do it with support.
Now, if you're a clinician watching this video and wondering who are the patients that you see in practice that may benefit from seeing a dietitian or getting nutrition support, in my presentation I outlined a few key red flags or indicators that may warrant referral, and that's really basketed into different, sections or priorities. So the number one would be any red flags of malnutrition. An easy way to spot that is any unintentional change in body weight or any change in dietary intake due to poor appetite. So there is an easy questions that can be incorporated into a doctor or a clinical consultation. Any evidence of fat or muscle wasting, edema, ascites are huge red flags of malnutrition. So they would be key things to look out for with regards to malnutrition.
Yep.
The other aspect of that is then any evidence of comorbidities. And that, again, is an easy something that could be screened as an outcome through a clinical consultation. So things like type 2 diabetes, hyperlipidemia, hypertension, PCOS in young women, or insulin resistance as well, on the spectrum of if that is left unmanaged and could potentially progress to something like type 2 diabetes, would arguably warrant an automatic referral to a dietitian.
Because we know that we have medical nutrition therapy specifically for those conditions.
Yep.
So established nutritional interventions.
The other little basket that we talk about then is symptoms. So if a patient presents with a symptom like a swallowing difficulty where they need a texture modified diet or support, speech pathology involvement there as well, anything with the gastrointestinal tract, so things like digestion, malabsorption, so when nutrients may not properly be absorbed, micronutrient deficiencies, bowel changes, bladder changes, as examples of symptoms that dietitians have direct nutrition therapy for. And lastly, if people are interested in diet,
If they're asking questions that you
Yeah.
don't feel that you can answer specifically.
unsolicited or overgeneralized advice can do more harm than good. So again, leveraging on clinicians that are trained and are experts in that field, let's leverage on the multidisciplinary team and refer.
Interesting. So, are there any platforms online or places where people can get a better understanding, any resources that can help people understand the risks and benefits?
Probably the best place to start in terms of reliable information would be those non-profit organizations, so National MS Society here in the US and similar organizations around the world. I think what I learned, one of the findings from my first study was that reliability of information is highly variable. There are a lot of personal analogies, personal experiences. So just a single person and the journey that they've been through. And it's great that people are sharing the journey that they've been through. Of course it is. But that's why we have rigorous research, because we can't base our recommendations on the findings of one person. There has to be a large body of evidence before we make recommendations to everybody.
I think that comes through a lot of online groups in MS, which is fantastic because social networking is so important, and
Support.
to speak with like-minded people as well is a huge benefit for those people in community. And in a few of those groups, people love sharing experience. And I think when it comes to things, again, that is modifiable or things that people can take into their hands, talking about diet is such a hot topic. And like Karen mentioned, anecdotes, personal experiences can really sometimes overshadow the evidence base. So if someone has a positive experience with a dietary pattern or with a way of eating, that might not be relevant for someone else. Everyone's needs are so different. Nutrition is not a one size fits all, just like how an exercise physiologist might prescribe an exercise program, that would be different from one person to another. So I think leading people to the evidence base is a huge part of our role. And that, like Karen said, National MS Society in Australia, we've got the MS Australia website. We've actually just now launched yesterday on World MS Day a modifiable lifestyle guidelines document. And that was a group of probably 50 plus content experts in all different areas of research. So we both contributed to the dietary chapter, comorbidities, stress, smoking, all of these things that go hand in hand with diet. And so directing people to something, like Karen said, non-profit organizations that showcase this evidence is probably the best place to start.
And of course, they will recommend that people follow dietary guidelines. We have to acknowledge there's resistance against dietary guidelines. Unfortunately, science is not as exciting. Science is not as exciting as the way that influencers deliver information about nutrition and diet. So sometimes science is boring, but it's underpinned by evidence, and we can't ignore that. So when it comes to dietary guidelines, there's a link between dietary guidelines, metabolic comorbidities, and outcomes in MS that's becoming a very strong link in the research. And that link is, if a person with MS is obese, or if they have diabetes, hypertension, dyslipidemia, so those metabolic risk factors, there's increasing evidence to show that their MS outcomes can actually be much poorer as well. So that's how following dietary guidelines, which directly address those metabolic comorbidities, can be helpful to someone living with MS. And that's one of the points that I really tried to make yesterday in my presentation. And Olivia followed that up with a wonderful case study. It's probably a good idea to talk about that.
Yeah, I think on the background of what Karen's talking about with regards to obesity and metabolic comorbidities, what is it, day 3 of the conference? And I think in every session so far that has come up from neurologists, EPs, nurses, consumers in their conversations as well.
Yep.
It's a really prominent theme and flavour of the conference. But what's missing from that conversation is that diet and exercise are first-line therapy for managing obesity and managing metabolic comorbidities. And I think as the role of dietitians, obviously we advocate for that. A lot of people may need to get their medical support or pharmacologic benefit if we find diet and exercise is not enough. But linking that back and trying to advocate for that last message to be in the conversation is a huge part of our work and something we're really passionate about. So as part of that clinical course yesterday, bringing to life Karen's research and the role of diet and dietitians in MS care, I then approached the conversation through a clinical perspective. So I am a researcher as well in MS, but I also work clinically in my caseload as people living with MS. So I think I get the dual benefit of seeing research and celebrating success with patients while contributing to the evidence base, which is extremely rewarding. And the 2 cases I presented yesterday completely marries up with what Karen's research is showing as well. So the first case that I unpacked was a man presenting. So he has MS, living with MS, relapsing remitting MS, diagnosed in 2016, which he's being treated with Ocrevus every 6 months. On presentation, he was largely overweight. So technically, according to World Health Organization, he was obese class 2. And on presentation, he had a pathology report that showed a long-standing history with dyslipidemia. So a red flag for me is that this hypertension, this high cholesterol and elevated LDL cholesterol was being untreated for quite a number of years. Key signs of metabolic syndrome, but an incomplete pathology report as well. So as part of my role is then advocating with his medical team to get more tests done. And that included following up glucose, for example, and seeing is there risk of diabetes. And that actually came back that showed he had long-standing type 2 diabetes, and that had never been mentioned to him before. So as part of my role in that, with my then clinical hat on, knowing first-line treatment is managing diet and exercise to support metabolic comorbidities, supporting that patient to achieve a healthy weight. I worked with him still working with him, it's been 16 months, and we don't really use the term that diabetes has been reversed, but his average glucose marker, so HbA1c, what we refer to in Australia, the cutoff for diabetes is 6.5%. When this patient presented, his HbA1c was 8.4, and his last report, now it's come down to 6.4. So technically, while we don't give the false hope that this has been reversed, we can encourage that this patient that his metabolic markers are extremely well managed. And like Karen said, the evidence we just cannot ignore with respect to lifestyle comorbidities and MS outcomes. So thinking things like disease progression, disability progression, rates of hospitalization, ambulatory disability, symptom burden and severity, and all of those things that are encompassing what people well manage with MS, if we can help to improve that from a dietary perspective, is absolutely key.
Yeah, we're having evidence now that BMI, an increase in BMI is directly associated with a reduction in grey matter volume. We cannot ignore that. We can't ignore that in this population, especially because this population of people have extra challenges. I mean, the general population, we live in an obesogenic environment. It's not people's fault if they're overweight or obese. It's difficult. It's difficult for everybody, but there's a lot they can do about it. Yep. So while there's not fault there, you can take the power and you can move to a healthier body weight. and thinking about the extra challenges being maybe reduced mobility, maybe being wheelchair bound, maybe a history of steroid use, maybe antidepressants as well, very common in this population. And all of those are things that we know to contribute to excess body weight. So it can be quite difficult.
From a dietary perspective, again, I keep talking about this toolbox, which sounds like this magical box of wonders that we can help patients with, which essentially it is. But through our training in dietetics, we're trained through what's called the nutrition care process. And I think it's really important. And I started my presentation yesterday by explaining that to the doctors in the room and the non-dietitian experts, as people aren't aware of our process. I think it might be a stereotype that people may present to us in clinic and, a patient sits down in front of us and from the get-go we're talking about diet and how can we help with diet, and it's all from this dietary perspective. But our dietary assessment, what we call it, is very in-depth and very detailed. So for the first 60 minutes of a conversation, we're collecting things like anthropometry, biochemistry, symptoms that may impact someone's ability to chew and swallow or get adequate energy intake in. And then we go on to diet as kind of the last add-on. So without that big picture of how someone is presenting to us, the key role of what we do is we prescribe something that is tailored,
Individualised care.
and individualized. Exactly.
It's not surprising that medical practitioners are likely to think about pharmacological interventions for things like those metabolic comorbidities because that's their training. It's completely understandable. But there is so much more we can give them as dietitians. And the things that we can give them relate to empowering people to accumulate those healthy habits for the rest of their life, because often people don't know how to go about doing that. They don't have the strategies. So it's not just the theory that we give them. I mean, often on the information sheets that patients are given, the theory's there, but not how to actually do it, and not how to actually do it in that person's life.
Yeah.
So a nutrition prescription, it sounds terrible actually, because yes, it's a thing, but it's more of a partnership when it comes down to it. It's more thinking about shared goals, agreeing goals, negotiating goals with the person that's sitting in front of us, rather than a top-down prescription. But we will call it that anyway. Nutrition prescription is different to a pharmacological prescription. We cannot expect a certain degree of adherence like we can with medicines. And that's because nutrition involves behavior change. It's not as easy as taking a pill. It's really, really hard. And we, as dietitians, don't typically try to change everything in the first consult. We might agree one or two things to start with and really help that person make that behavior change. And once that's established, then they come back and we work on a little bit more. And that's why Olivia's been seeing her patient for 16 months.
Yeah. And sometimes the actual diagnosis, if we get back to the process of nutrition care, the diagnosis might be that that patient is not ready for change. And that's really common, that it might be, like I've had experienced patients present to me in private practice, and it's purely my neurologist told me to come, or my GP or a family member begged me to be here because I've got fecal incontinence, for example, and I need support. But that patient is not ready to take on any information. They're not ready for change. So their diagnosis in that point is they might not be ready. So that's a huge part of this whole behavior change process. To be able to make long-lasting impact, the patient has to be ready for it. It's a huge lifestyle change in most cases, and some people are not in the right mindset. So it establishes a great need to, again, advocate for our role and get the whole medical team on board so they can be hearing that same message. I love the saying, speaking from the same language.
Yeah.
So the whole medical team, we're advocates for it. We all must be speaking from the same language, and to get that person on board and get the trust from that patient is really important.
I feel like when it comes to multiple sclerosis, there's no stone that we can leave unturned. We really have to support that person in every aspect of their life. Again, coming back to brain health and thinking about all of those elements that feed into it, it's a multi-pronged approach.
Yeah.
But of course, we don't want to overwhelm that person either. It's about just choosing the right time, introducing some small changes, changing thinking about what they can do. But, for most of us, we have a reserve. We can sort of get away with unhealthy habits for a while. But I think when you have a chronic condition, and I have one as well, you can't afford that anymore. It's important for you to start thinking about making those changes.
I think what you haven't spoken about as well is malnutrition. That's a
That's
huge
the other
area that you
side.
love.
Yeah, that's right. So malnutrition is underlooked in multiple sclerosis. There's a type of malnutrition called sarcopenic obesity, and what that is when the person has a high fat mass and it masks what is happening with muscle wasting underneath. So it can be really difficult to diagnose to diagnose malnutrition, and certainly for practitioners to recognize it. They see that the person is overweight or obese and they feel they need to lose weight. But what they don't realize is that they have a poor strength and conditioning status underneath the fat mass that's masking what's happening. So it's really important that if a person has lost weight recently without trying, so unintentional weight loss is what we call it, or if they have been eating poorly due to a poor appetite, or maybe some of those other symptoms that are common in MS that can be barriers to adequate nutrition. So things like dysphagia, which is difficulty swallowing, difficulty with mobility, maybe fatigue, maybe a loss of income. The problems can be social as well. And vision impairment, cognitive impairment, all of those things can be barriers to nutritional adequacy. And sometimes that can also lead the person to making poor food choices because they're convenient as well. So if those things are happening, unintentional weight loss and not eating so well, that's typically an indication of a referral to a dietitian to unpack that and start addressing those things that are barriers to adequacy. And certainly the effects of disease-related malnutrition, so things like increasing risk of wounds, like delayed wound healing. Now, that's really important for people with MS. They may be using a wheelchair. They're already at increased risk of a pressure area. We want to make sure that their nutritional status is as good as it can be so they don't have that kind of breakdown. And other things that are associated with DRM, so disease-related malnutrition, increasing hospital stay. Again, just being an inpatient in a hospital increases your risk of malnutrition. Increasing costs as well, increasing risk of infections. Again, for people who are immunocompromised because of the medications that they're on, they already have an increased risk. If they're malnourished on top of that, it further increases that risk. Also, reduction in quality of life. That's a big one as well. So it's really important to identify malnutrition early and to treat it as early as possible.
So that was one of the case studies that I presented yesterday as well. So in the clinical course, the first part was really presenting one end of the spectrum about metabolic comorbidities, which I went through earlier. On the complete other end is the malnutrition perspective, which Karen mentioned, the complications in MS. So all of those things, but respiratory muscle weakness, for example, increased rate of injury from falls, increased risk of micronutrient deficiencies are all really prevalent. And in MS, arguably are more heightened as something that should be avoided or we try to avoid. So an example from my clinic, and this is something I presented yesterday, one of the patients, it was actually referred from that patient that I spoke about earlier. So they were good friends, and he had quite a lot of concerns about her weight and reducing or her body composition change over time. So when that patient presented into clinic, she was just about 40 kilos, and her usual body weight is about 15 kilos heavier than that or higher than that. And the patient, again, through our nutrition care process, we don't jump to food straight away. It's actually quite inappropriate at those time points. So getting a bit of a journey and story from that patient and building rapport is the first part of our whole encounter. And that patient described quite a awful situation actually about being told that she was allergic to sugar from a blood test result in 2001. So for the last 25 years, her eating pattern has completely changed in fear of what might happen if she has any form of sugar or carbohydrate. And something that a statement might come across as just a sweeping statement from a doctor at that point in time, people don't realize the detriment that can have on someone's life. So for over 20 years, this person has lost over 70% of her total body weight and presented to clinic with a fear of what do I eat? She had a history of juice cleansing from her MS. So on her diagnosis around that time in 2001, someone or a relative from her family had given her a book of different juice cleansers for different symptoms of MS. And one of her biggest symptoms was slow transit constipation. And no one had supported her from a bowel management perspective. So what else was she going to do than try things that were given to her from relatives and friends and things that she had found online? So from this juice cleansing, that was just washing her out, making it extremely difficult to gain weight. And from a dietary perspective, arguably that we're in the best position to support patients in that situation. So when she presented to clinic, she was mobilizing with 2 canes, and that was purely just fear of, if I was to have a fall, what would happen? Bones were protruding. She had muscle wasting and
Very deconditioned.
Very deconditioned. So working closely with an exercise physiologist to promote strength and conditioning. From a dietary perspective, we talk about things like fortifying meals. So saying to a patient, have another main meal in a day is not realistic when they've got poor appetite, cognitive fatigue, they can't prepare their own meals, for example. So a strategy that we can use is fortifying foods, which is technically getting more bang for your buck. So adding in calories and protein to something that is already established in her diet. We also have a tool that we can prescribe, an oral nutrition support product. And there's so many out there at the moment, which I think is awesome for us.
Here it's Ensure.
Ensure, as an example. In Australia, we've got ones that, say in a 200-300 ml bottle, it's nearly the size of a main meal in regards to calories or protein, if not more. So getting more bang for your buck in the sense of not having 500 snacks in a day, that is completely unrealistic, but adding in calories and protein to what is established. And again, we see these patients over a long period of time. So over about a 14-month change and education for this patient of how to live well with MS, how to restore body composition, lean body mass, gain fat mass, which is okay at 65 years old. If you're going to have a fall, it's actually a method of protection from bones.
The ideal body weight, or the BMI, we know that's not an ideal measure, but it is a little bit higher in older people. Yeah, the outcomes tend to be better when they're carrying a little bit more.
So educating that for a patient and doctors, because they're rightly so probably not aware from their training as well, supporting that patient through the dietary approach, fortification, oral nutrition supplements, and working with her exercise physiologist. She was able to restore back to her usual body weight. Her bowels improved, fecal incontinence, her slow transit constipation. She was opening once a day and feeling fantastic. And the biggest outcome from that is that last appointment, she came in with 1 cane. So from a mobility perspective, she had increased strength and conditioning. I feel like I almost tear up every time I talk about that.
I knew this was going to happen.
From a strength and conditioning perspective, it's just amazing.
I think that as a dietitian, there's nothing more satisfying than seeing an actual outcome that is a multiple sclerosis outcome. Once a person's nutritional status has been restored, that's why we do it. And honestly, it's really hard. It's hard work establishing who we are and what we do. We know that we're still up and coming and there's a long way to go, but it's those patient stories that keep us going.
Yeah. And arguably for a patient, most people present, especially if they're living in an overweight body or a larger body size, weight is always the primary end point for a lot of these patients. But thinking things back to MS, for both of these patients that I've spoken about, when they follow up with neurologists, there has not been evidence of any disease activity.
That was your first case study you didn't mention.
And not to say diet is the only thing that is going on, because it's absolutely not. That second patient with malnutrition has primary progressive MS and is not currently receiving treatment. So her treatment we shape to her is holistic. Like, it's the only treatment we have for her is brain health and lifestyle and eating well and exercising, seeing her speech pathologist, seeing her OT, making sure she's safe in the home, for example.
Managing symptoms.
And overall quality of life. That is her management strategy, and arguably calling on team members that are best placed to support all of those elements is MS care. And I think that the biggest flavour of what's coming through as well in this conference is that comprehensive MS care. And what is that? And I think that message, especially from June Halper, the message that she has promoted through her clinical care and her advocacy work is comprehensive MS care, and involving a multidisciplinary team is the basis to that. And I think you can probably tell we're so passionate about it when we're speaking about it, but we have seen firsthand the outcomes that this can have on patients' lives. And again, not coming back to the sense that we don't give patients false hope that diet and exercising in combat to that and maybe stopping smoking will completely cure MS. We're very realistic and we don't want to provide that false sense of hope to people. But if that can improve symptoms, if that can improve things like brain scans, as we know, like we said, the obesity and metabolic comorbidities and the outcomes that are associated, the evidence base is too strong to ignore. And speaking to people all around, I think we're one of few dietitians at this conference, and people love speaking to us because they say, oh, patients come to see me and they find they're doing better following a gluten-free and lactose-free and dairy-free eating plan. How can I help support that patient? And
that's a very common thing. Before we move on from that, so people start following a diet that has restrictions and all of a sudden they perceive that they feel better. What's very likely happened is that they've moved from a Western diet, which has a lot of processed food, foods that are high in saturated fat, added sugar, added salt. They've moved into a different eating pattern. Yes, it may be restrictive, but it's probably cleaned up quite a bit and they're noticing a benefit. But if they tried to move towards healthy eating, they would very likely also observe that benefit.
Yep.
And then they wouldn't be at risk of nutritional deficiencies as well. Yeah.
This has been fascinating. So is there anything that you'd like to add, anything that we haven't touched on, or any parting words for fellow healthcare providers?
I think the only thing I will add into the conversation is this whole idea of brain health that is being spoken about at the conference, and that then links back to the research and my PhD that's been completed a few months ago now, which is awesome. All of my research is regarding lifestyle support that can maximize lifelong brain health, and through presentations that are being promoted here and sessions at the CMSC conference, a few of the papers that we've published have been cited, which is awesome. So that's going international, but the whole picture of it. And I think I tried to get that from a few of these case studies where I'm talking about calling on other allied health professions to support MS care. This idea of brain health is first-line therapy for people with MS and is crucial and is a priority target area from both disease management, so a pharmacologic perspective, and a lifestyle perspective. So encompassing things that, well, MS is a disease of the brain and the central nervous system, and anything that we can do to support and maximize lifelong brain health arguably is the center of comprehensive MS care, and that involves a multidisciplinary team as we're getting more established with the role of diet in MS and calling upon those professions in the space who are best placed to provide that support would be my biggest take home.
And we do have work to do. There is catching up to do. So the evidence for diet, the diet-disease relationship in multiple sclerosis, it's building, but it's not there yet. So we talked about that large body of evidence that underpins and informs dietary guidelines. Clearly, they don't come from nowhere. We can't make recommendations to the general public without a large body of evidence. We need a similar large body of evidence for diet and MS. It's fascinating and it's wonderful and it's so exciting to hear a lot of that research is being done. So we're working on it, but we do have catching up to do. So while at this point in time, we're recommending that people are not following restrictive eating patterns, it's important that the research continues into those eating patterns as well, because we don't want to miss anything. So if something does emerge, obviously we want to catch it. So
we had that conversation yesterday. We're a little bit behind in the timing compared to other established areas like exercise, and that's okay. I think every area of behavior change starts somewhere.
Yeah.
We've got a little way to go, and I think we've got a long way to go in still promoting our role and how we can support patients at the center living with MS, but exercise got there and is
Yeah.
still getting there, and showcasing the benefits that exercise might have.
And what we do is evidence-based. That's why we come to these conferences. So we want to hear the results of these studies, and then we adjust our practices in response to what we're hearing as well. So it's really important to keep on top of the latest research. And that's research at the mechanistic level, looking at individual nutrients, interactions with disease processes, the influence of certain foods, and of course, whole diet, which has been the focus of my PhD.
You just brought something to mind to me. So I wanted to ask you about gut health.
Have you got another 2 hours?
Exactly. So I'm just wondering if you can give me just a little taste. I can imagine that there is a ton of crossover in your field and gut health.
Coming back to fibre. So we talked about restrictions on grains before. Fibre is a prebiotic for healthy microbiome. So if a person isn't getting enough, what's the impact on the microbiome going to be? Olivia has done a little bit of investigation into microbiome.
Yeah, microbiome, I think, is a buzzword in every condition,
As it should
let
be.
alone just MS, and an emerging space. So we're learning more and more every day. In MS, I think when we come to what do we promote or what do we suggest for people to establish a healthy gut microbiome, it's probably quite similar to the general population, talking about things like fiber, prebiotics and probiotics, if that's safe as well. Through research that I have conducted, I've actually looked at the oral microbiome. So the gut microbiome would be the largest biome system in our
GI tract.
in our GI tract. The second to that would be the oral microbiome. And we've looked at that purely from the perspective of it's less invasive for patients to do some testing. And so we conducted a clinical trial with mouth swabs for people living with MS and matched that to healthy controls related to their sex and BMI. And we found some really awesome results. That's only one of, I think, 3 studies that have looked at the oral microbiome in the world, to my understanding. So it's a pretty groundbreaking research, which is under review. So hopefully that's published shortly. And and we did find, generally speaking, though, a huge difference between healthy and matched controls with regards to the composition. So in microbiome world, we talk about diversity and abundance. So diversity is how many species might be living in that area or region, and then abundance, is there one species that is dominating that? Generally, we want a diverse microbiome, and we don't want any one species that is overriding or being too abundant in that condition. And in multiple sclerosis, in our patients or our cohort living with MS, they had a less diverse abundance of oral species, and they had certain species that were more abundant and actually not even detected in matched controls. So people that weren't living with MS, which we have found from research and taking learnings from other conditions like Parkinson's disease and Alzheimer's, that a few of these species are actually directly linked through blood-brain barrier function, getting tongue-tied, and neuroinflammation. So,
I was going to say that because there is a study that came out recently that even talked about the brain having its own microbiome. It's interesting to think about what that microbiome might mean for the way that we think and feel and the ways that our brain ages and what types of, implications that could have on life, especially when we think about some of these types of diseases that we're discussing here that also have neurological impacts. It's absolutely fascinating.
Thinking about anything with a mucous membrane essentially having a microbiome because of the interaction with the external world. I think Ekstrom's last year was talking about the lung microbiome, and then you start thinking about, well, the effects of smoking. Of course, it all makes sense that that's a risk factor for multiple sclerosis.
Yeah,
Fascinating.
it's really fascinating. The patients or the cohort that we sampled, they're on a range of DMTs as well. So a few of them had orals, some were infusions, some were injectables, and even the differences in that and how that's affecting composition of species that are present in the oral microbiome. I think watch this space. Absolutely. It's a huge area. And I think we're only at the surface of what we know.
Yeah, I'm really excited about this. There are so many things that I could think of that I can't wait for the results to come out, because I'm even thinking of composition versus the rate of disease progression. I'm thinking about so many things like comorbidities, for instance, and I'm thinking about inflammation in general as well as a big deal.
Yes. disease processes. So inflammation has an impact on requirements, nutritional requirements.
Mm.
So they tend to be higher when inflammation's present, also catabolic processes as well. So two disease processes that we know are happening in multiple sclerosis.
Yeah, and you have these anti-inflammatory diets that people think about as options. And I'm wondering if any of the successful diets focus on anti-inflammatory foods.
I suppose, and I haven't looked at this closely, but there's probably a correlation or a bit of an association
Mm.
between anti-inflammatory foods and an eating pattern like the Mediterranean
Yeah.
eating diet. So it's probably a fairly loose link
Yeah.
between those two. And even though we package one diet in a particular way, it's actually loosely related to another one that actually has a lot of evidence behind it in MS. And certainly when it comes to a Mediterranean approach, it's very close to the dietary guidelines. It's a safe one to start with because it's not very restrictive and it encourages those healthy foods that we have evidence for having positive effects in the general population and in people with MS.
One thing that's always mentioned across conferences has been the use of artificial intelligence and machine learning to enhance research processes, as especially as we find so many additional elements that impact disease and we move towards personalized medicine. So I'm wondering, in your work and your research, have you thought about how this type of technology might be used to look at your past data, how it might be impacting the lives of patients? We've talked about people doing their own research on various diets online, and the just overwhelming amount of information that's surrounding that. We've talked a lot about the different elements that go into things like microbiome and so many things.
There's definitely capacity for a massive model that takes all of these things into consideration, definitely. And look, it's jumping ahead, isn't it? And our supervisor spoke to that yesterday, actually. So we need to be thinking about AI and where we're headed. Certainly in my research, I use it. I use it for coding. I use it to help me find papers. I use it for all sorts of things, and it just shortcuts the process, and then I can spend more time doing actual research. But in terms of how people living with MS are using it, I had a look at that in my first study as well. I asked ChatGPT what the best diet for MS was, and it actually came back with quite a reasonable response, but I don't know if it's the same today. It
Yeah.
might be slightly different because things have moved on since then.
So, are there conversations about using it to help you all analyze your data at all or look at different intersections and things like that?
We have to be a little bit cautious about sharing data just because of patient privacy. So at this point in time, we have some guidelines at our university that doesn't allow us to use ChatGPT for analyzing data that uses actual people's data. So that's probably the main limitation at the moment. But I imagine that there will be much more specific tools developed in the future, specifically for scientific research and for analysis. And certainly I think that functionality is definitely emerging.
From my perspective, if I can add to that as well, as part of my postdoc, I'm running a weight loss intervention, so an RCT to support people living with MS to achieve and maintain a healthy body weight. And as part of that, it involves dietary consultations. And while AI we hope at the moment won't replace clinicians' role because of that interaction and rapport that we can establish, we're actually leveraging AI to support with our transcription of notes. So, as all patients that come through our trial require a clinical record and a medical record with regards to progress and monitoring outcome, intervention, and our action plan, we're actually utilizing a service that's available. I know it's in Australia, it could potentially be international as well, called Heidi Health. And it's a very common clinician tool that researchers are using and clinicians in Australia to support the note taking and medical records to support from a time perspective, as well as intervening with regards to documenting action plans and following that up. So with regards to data collection, I think we're more in the stage of being comfortable for using AI in leveraging that. From an analysis perspective, I think there are some more policy and guidelines that are needed
They need to
from,
catch up.
a confidence perspective.
Well, thank you so much for joining us on MD Newsline. It's been an absolute pleasure.